Great. So so I think we've got just about all the folks who are going to join. I see the number keeps growing, but I want to go ahead and get started so our panelists have the full amount of their time to share their information with us. So hello, everyone. Wanted to welcome you to the TAA's National Conference, our TIC-CON. I'm so glad, we are also glad that you've joined us today. Before we begin, I wanted to introduce myself. I'm Elizabeth Barker. I'm the director of our volunteer and affiliate network here at the National TAA. I'm here to help moderate this session. If you have any questions, you can send me a direct message in the chat if you need any assistance. You can also put any questions in the chat for the Q&A. I wanted to inform you that we'll be offering transcriptions and translations for our sessions, and I'm going to put that in the chat for you to get more information about that. So let me send that chat. Okay, numbers still growing. This is fantastic. Fantastic. We've got a big audience this morning. Okay. It's growing. Maybe I'll give them one more second to get everyone's Zoom up and running. Okay, I'm going to go ahead and introduce our speakers this morning. This morning, we're joined by Dr. Jennifer Vermilion, who is an assistant professor of neurology and pediatrics at the University of Rochester, where she's also the director of the Pediatric Movement Disorders Fellowship. Dr. Vermilion received her BS in molecular and cellular biology from Vanderbilt University and her MD from the University of Rochester. She completed residency training in child neurology at the University of Rochester, where she stayed on to complete a dual fellowship in pediatric movement disorders and experimental therapeutics. She then joined the faculty at the University of Rochester in 2019 and co-directs the Tourette Association of America Center of Excellence at the University of Rochester. So thank you this morning for joining us.
Thank you.
We also have Yelizaveta, who is a medical student at the University of Rochester School of Medicine and Dentistry. She's currently conducting a research fellowship year out, focusing on anxiety and Tourette syndrome. Yeli received her BS from Cornell University, where she majored in biology with a concentration in neuroscience. As a medical student, she realized she was interested in pursuing biology, pediatric neurology, as she enjoys learning both about brain physiology and finds caring for children particularly rewarding. She plans to apply for pediatric neurology residency in 2023. So thank you both for joining us, and I'm going to turn it over to you.
Great, thank you so much. Let me just pull up our slides. Okay. Can everyone see the slides?
Yep, I see them.
Perfect. Okay. So thank you so much for that introduction. Today, Dr. Vermilion and I will be discussing the anxiety and tic link. These are our disclosures. Our learning objectives for today are to understand how anxiety and tic disorders affects function and quality of life in individuals, to be able to describe the relationship between tics and anxiety, and to understand how anxiety symptoms may interact with the neurobehavioral model of tics. So why are we focusing on anxiety and tic disorders today? 1, anxiety disorders are common in children with tic disorders. Approximately 30 to 50% of children with chronic tic disorders have at least one co-occurring anxiety disorder. And in a community-based study by Kurlan et al., anxiety disorders were nearly twice as likely to occur in the tic disorder group as compared to the non-tic group. Oh, sorry. 2, anxiety may start earlier in youth with chronic tic disorders than in youth without chronic tic disorders, and the emotional symptoms tend to persist and may worsen in older age groups. 3, anxiety symptoms negatively impact youth with tic disorders, as will be discussed later in this talk. And 4, anxiety symptoms and tics interact, as will be discussed by Dr. Vermilion in terms of the neurobehavioral model. So what do we know about anxiety and tic disorders? Anxiety symptoms matter to patients and families affected by tic disorders. For example, in a study by Cuenca et al., including 295 online survey responses by parents of children with Tourette syndrome and 42 in-depth interviews of children with Tourette syndrome, the study showed that children with tic disorders identified that anxiety and stress contributed to the worsening of their tics. Both parents and youth with tics identified anxiety-related emotions as troublesome, and in interviews of youth with chronic tic disorders, the reduction of negative emotions, including anxiety, was the second most desired outcome of treatment reported by participants following tic reduction. Additionally, anxiety may start early in youth with tic disorders. In a large cross-sectional study conducted by Hershit et al., consisting of over 1,000 participants with Tourette syndrome and over 1,000 unaffected family members, it was found that subjects with Tourette syndrome may have an earlier onset of anxiety disorders as compared to the general population. In this graph from their study, the y-axis shows the different comorbid disorders with a box around anxiety. The x-axis shows their age of onset. The dots in each graph are the median age of onset, and the bars are the interquartile range. The width is proportional to the number of people with a given age of onset. The median age of onset of Tourette syndrome was around 6, and anxiety disorders typically start within a year of the tic disorder diagnosis. The high-risk period of anxiety disorders was broad, ranging from 4 years of age into adolescence. So based on this, it is important to screen early and often for anxiety in youth with tic disorders. Additionally, prior research has shown that anxiety and quality of life are related. There was a study conducted by Dr. Vermilion et al. Assessing the impact of tic disorders on quality of life and family function. Children's psychosocial quality of life, including behavioral problems, mood symptoms, and self-esteem, was evaluated by the Child Health Questionnaire Parent Form 50. Anxiety symptom severity was found to be significantly associated with worse child psychosocial quality of life. However, this study did not find a significant association between anxiety severity and the Family Impact Score, which was measured by the PEDS-QL Family Impact Module Questionnaire. So what do we still need to know about anxiety? We want to know what the phenotype of anxiety symptoms and anxiety disorders are in youth with tic disorders. We want to know how anxiety affects function in youth with tic disorders. We want to know how anxiety and tics interact. And lastly, we want to know how we can best manage symptoms in an anxious youth with tics. So going into some ongoing studies, as part of an ongoing cross-sectional study with youth ages 6 to 17 with tic disorders, the youth and their parents participate in a variety of questionnaires assessing for the presence of anxiety and assessing their tic severity, global functioning, and many other symptoms. The youth were selected for tic disorders from the University of Rochester Child Neurology Clinics, but were not required to have an anxiety disorder diagnosis to participate in the study. Currently, we have enrolled 33 participants. One of the questionnaires conducted as part of the study is the Anxiety Disorders Interview Schedule, also known as the ADIS. The ADIS is a clinician-administered survey, which is the gold standard for assessment of anxiety disorders in pediatric clinical trials. Another questionnaire we administer is the Pediatric Anxiety Rating Scale, or the PARS, and this is another clinician-administered survey, which also evaluates for a variety of anxiety symptoms and measures anxiety symptom severity over the previous week with the input of both the child and the parent. The range of the 6-item score on the PARS is 0 to 30, with higher scores corresponding to worse anxiety severity. Shown in this table to the left, anxiety disorders are very common in youth with chronic tic disorders, with approximately 79% of youth in our study having at least one anxiety disorder as determined by the ADIS. The most common anxiety disorders were found to be generalized anxiety disorder and social phobia. Specific phobia. The graph on the right describes anxiety severity as demonstrated by the 6-item score on the PARS. The 6-item score is on the x-axis, with scores increasing from left to right. The number of participants is on the y-axis. The arrow shows the level for clinical significance, and as you can see, clinically significant anxiety is also very prevalent in youth with chronic tic disorders. So to summarize this slide, anxiety disorders and clinically significant anxiety are very common in youth with chronic tic disorders. Next, I'm going to discuss some of our research on the functional impact of anxiety in youth with chronic tic disorders. In another ongoing study of ours, a survey asking about anxiety symptoms and treatment was distributed to parents of youth with tics who also have anxiety or are worriers. In this study, parents reported that anxiety interferes with their children's function, with only 9.4% of parents reporting that anxiety does not affect their child's function at school, and only 5.7% reporting that anxiety does not affect the family dynamic. Parents also reported many anxiety symptoms in their children, with the most common being that anxiety causes their child to feel overwhelmed and irritable, and that anxiety causes their child to have difficulty concentrating in class. And this is outlined in the table to the left. If we go back to the previously discussed ongoing cross-sectional study, when looking at data from the PARS, the majority of participants also reported that anxiety had an interference severity of at least mild or higher in terms of affecting the child's interactions, both inside and outside of the home. And in this slide, the family effect is on the left, and the effect on the child outside of the home is on the right. In the same study, we also evaluated children's tic severity based on the Yale Global Tic Severity Scale, or the YGTSS. The YGTSS is a clinician-administered tool used to evaluate tic severity over the previous week with the input of the child and parent. The total tic severity score ranges from 0 to 50, with 0 being the lowest severity and 50 being the highest severity. The graph on the left describes tic severity as evaluated by the YGTSS in youth with and without an anxiety diagnosis. The x-axis is the tic severity score, with worsening tic severity going from left to right, and the y-axis is the number of participants. At the top, we have children without an anxiety diagnosis, and on the bottom, we have children with an anxiety diagnosis. We demonstrate that children with at least one anxiety diagnosis have significantly higher or worse tic severity than children without an anxiety diagnosis. In this study, we also evaluated the youth's global functioning based on the Children's Global Assessment Scale, or the CGAS. This is a clinician rating tool, and this tool evaluates youth's general functioning. The range on this tool is 1 to 100, with increasing scores correlating to higher functioning. The graph on the right describes the global functioning as evaluated by the CGAS in youth with and without an anxiety diagnosis. Similarly to the left, the CGAS score is on the x-axis, with increasing scores from left to right. The y-axis includes the number of participants, and participants with no anxiety diagnosis are at the top, and participants with an anxiety diagnosis are at the bottom, and that is also determined by the ATIS. And our study finds that participants with an anxiety diagnosis have significantly lower functioning than those without an anxiety diagnosis. When we look at specific anxiety disorders as determined by the ATIS, we find that they are also related to a child's function. The graph on the left describes tic severity in children with and without social phobia, and the graph on the right describes tic severity in youth with and without generalized anxiety disorder. In both graphs, tic severity as evaluated by the YGTSS is on the x-axis, with severity worsening from left to right. The number of participants in both graphs is on the y-axis, and youth with the respective disorder, so social phobia on the left and generalized anxiety on the right, are at the top of the graph. Youth without that disorder are at the bottom. Our findings show that children with social phobia and with generalized anxiety disorder as determined by the ATIS have significantly worse tic severity than children who do not have social phobia or generalized anxiety disorder, respectively. So to summarize that component, our ongoing research confirms that anxiety is common in youth with chronic tic disorders, and that anxiety in youth with tic disorders significantly impacts their daily functioning and worsens their tics. In terms of treatment of anxiety, currently youth with and without chronic tic disorders are treated the same way. For children with mild to moderate anxiety, psychotherapy or cognitive behavioral therapy is first line. In those with moderate to severe anxiety, medications with or without cognitive behavioral therapy are the gold standard for treatment. In the ongoing survey study described earlier, parents were asked to describe how anxiety or worrying is treated in their child with a chronic tic disorder. The majority of parents reported that their child has tried either both medication and therapy, which is in the yellow in this pie chart, or just therapy, which is in the gray. Only 4% of parents reported their child has tried only medication, which is in the orange, and only 8% reported that their child has not tried any treatment for their anxiety, and this is in the blue. A total of 47 out of the 53 participants reported that their child has tried therapy. A total of 26 reported that their child has tried medication. When looking at the reported improvement in anxiety in response to medication and therapy, the majority of parents in both the patients treated with medications and patients treated with therapy groups reported mild improvement in their child's symptoms. However, only 30% of parents reported significant improvement in response to medication. This is outlined in the gray on the left, and only 19% reported significant improvement in response to therapy. This is in the gray on the right. When evaluating why more parents did not try a medication, the most frequently reported reasons were wanting to try therapy first and concerns about side effects. This is described in the table to the left. Other reasons included symptoms not being severe enough and medications never being mentioned by a provider. Despite participants seeming to prefer therapy to medication, with 89% of the children in the study having tried therapy, almost half of the participants whose child received therapy reported barriers to receiving it. The most frequently reported barriers were insurance not covering it and difficulty getting an appointment. Other barriers included the child having difficulty talking with a stranger and services not being offered in the area. And this is outlined in the table to the right. I will now hand the discussion over to Dr. Vermilion, who will be discussing the interplay of anxiety and tics further.
Thank you so much, Yeli. Yeli was talking about the different kinds of treatment that we have out there for anxiety. And one area of interest is what happens when we treat anxiety, what happens to the tics. And clinically, what we will often do is say that in an individual who's quite anxious and has tics, we might try to target the anxiety first. But we don't really have data on what happens with that. And so a question that many have is, well, does anxiety treatment actually improve tic severity? And I'm going to talk a little bit about some of the data that might support that hypothesis. Next slide. So one question is, what is this relationship between anxiety and tics? We know that clinically there's some kind of relationship. A number of individuals with tics will say that their tics worsen when they're anxious or when they're stressed about something. But is that a direct relationship? Does anxiety directly worsen tics? It's hard to say. When we look at the data in terms of the anxiety-tic relationship, there's data to support, as we showed here and others have shown before, that those with anxiety disorders tend to have more severe tic disorder. But when you look at anxiety symptom severity and tic severity, those studies are somewhat mixed. And we also know that not all individuals with tics have anxiety. So it's probably not a simple direct relationship, but perhaps a bit more complicated. Another question could be, well, is it an indirect relationship? And perhaps there's some element that's indirect. This is a study done by Adam Lewin's group where they wanted to look at the role of anxiety and depression in how tic severity affects function. So they looked at 500 adults with Tourette syndrome, and they assessed tic severity and the effect on disability functional impairment. And what they found is there is a relationship between those two, and that relationship is even stronger for those who have elevated anxiety or elevated depression. So there's some kind of indirect relationship probably at play there. One way to conceptualize how anxiety might affect tics is to go back to think about, how do tics develop? How are they perpetuated? And I think it's important to remember this neurobehavioral model of tics. The neurobehavioral model of tics really is strongly rooted in the understanding of the premonitory urge. So the premonitory urge is that sensory experience that an individual will have that's usually experienced as negative or aversive. It tends to build and build and build the individual will perform the tic and often will experience some relief from that feeling, and then that cycle will continue. The urge can be a focal kind of symptom, such as itchiness behind the eyes for somebody who has an eye blinking tic, for example, or it might be a more general kind of feeling in the body, like a tension building up. But what is thought to happen is that because you experience that relief when you do the tic, this causes a negative reinforcement. Your brain says, oh, I felt better after I did the tic. And so it really strengthens that cycle and perpetuates the tics to continue. This is actually the basis for the behavior therapy that we recommend to treat tic disorders, comprehensive behavioral intervention for tics, or CBIT. And CBIT has a number of components to it, but one of the main pieces of it focuses on habit reversal therapy. Habit reversal therapy teaches an individual to recognize, I have an urge coming on, to develop a competing motor response, so they do something different from their usual tic. And by doing that, they can break that urge-tic relationship. And this is really based in what our understanding is of neurobiology in the basal ganglia. The basal ganglia being the part of the brain that helps you select the motor patterns you want and inhibit the motor patterns that you don't want. So the thought is that if you're doing a competing response, you have this other motor pattern going through the basal ganglia. And so then you're actually able to better inhibit those motor outputs that you don't want, being the tics. So with this urge-tic relationship, how could anxiety potentially interplay with that? So when you look at the relationship between urge severity and tic severity, we find that the data are somewhat mixed, but for the most part, there is a relationship between the two, such that those with higher degree of urges also have a higher degree of tic severity. And that makes sense at face value. You would kind of expect that. And then how does anxiety interplay with that? So there's a number of studies that have been done that suggest that anxiety is intertwined with the urge in some way, and that might play a role in perpetuation of tics. So in a functional MRI study done by Wong's group, they looked at areas in the brain that are lit up and more active during the time of somebody spontaneously having a tic versus somebody intentionally doing a tic. And what they found is there were a number of areas that are more active during those spontaneous tics, like what we would see in somebody just generally ticking. One area of activation was the amygdala. The amygdala is a key part of the limbic system and is thought to be a key player in anxiety. And so the thought was that this area might be more related to that urge that comes beforehand and that kind of uncomfortable sensation that comes before a tic. And so if that uncomfortable sensation that comes before a tic has some activation in the amygdala, there might be some relationship there. And then Rosamund's group, they looked at the relationship between urge and tic severity, and they also looked at anxiety symptom severity. Do those with higher symptom severity of anxiety have higher urge severity? And they did find a relationship between the two, with the strongest relationship being those symptoms that are more somatic, what they're feeling, aligned with more physiologic arousal. And then Ramsey's group looked at a really interesting study looking at distress tolerance. That's your ability to handle distress or discomfort. And they looked at how individuals are able to handle the discomfort of an urge. And they found that in children, the ability to have that tolerance of distress or tolerance of the urge is lower in those with higher internalizing symptoms such as anxiety. And so that might have an impact on how they're able to engage with things like behavior therapy, where being able to be uncomfortable in that urge is really important. So what do we know about the neural circuitry and how this might support or refute an anxiety-tic relationship? And it's complicated. We know there are a lot of different connections within and between neural circuits, but the cortical circuits and the subcortical circuits that underlie mood and movement disorders, they're complex, and we have to think about the circuits that are working in parallel, in serial, and then those that are interactive. So parallel circuits are really important. We have input from our cerebral cortex that initiates our thoughts, emotions, and behavior. And then these circuits act in parallel as they go through the basal ganglia to allow us to select desired thoughts or behaviors. We call that selective facilitation, and to inhibit those behaviors or thoughts that we don't want. And those are surround inhibition. And that's demonstrated in the picture all the way to the right from the Mink model of that selective facilitation, those things down the center, and keeping those other things from happening, that surround inhibition, which we think is affected in some of these disorders. But it's not all in parallel. We know that there's some serial effects too of these circuits. And so this is work done by Suzanne Haber's group, where what she showed here is that there is a directionality to these circuits. So the lines in pink up at the top, the orbital and medial prefrontal cortex, that includes the limbic system. So that's our mood kind of area. And that interacts with multiple different circuits to affect your motor at the bottom, the blue. And so it's not a direct relationship, but through a number of different circuits that this relationship occurs. And there's also crosstalk between these different circuits. So what does this mean for these different disorders? In thinking about how we can best work, how our bodies work, we need to be able to select the wanted behaviors, thoughts, and movements and inhibit those that are competing and would impair us from doing those things. And that requires all of these circuits to be working in parallel, in serial, and then to be communicating with each other. So what does this mean for treatment? So hopefully I was able to show you some that these mood and motor disorders have overlapping circuits, that mood and movement disorders have shared features where we're trying to select wanted things and inhibit unwanted things. And if we understand the circuitry, this can inform how we design and how we test treatment approaches that may be able to target more than one symptom. So for example, this diagram to the right of Godar and Bortolato, they made a beautiful diagram showing this habit formation between urge and tics, but all the external factors that are at play and can affect the urge and affect the formation of and strengthening of this relationship. And stressors such as anxiety are a big external factor that plays into this. And so can you target things upstream, like anxiety, to affect downstream things like the motor output or tics, for example? So in summary, what we were trying to show you guys today is that anxiety and tic disorders are common and functionally impairing, that anxiety disorders are associated with higher tic severity in youth with tic disorders. We think that anxiety probably does interact with the premonitory urge in some way and likely affects the neurobehavioral model of tics in that way, and that treatment of anxiety has the potential to improve tics and tic disorders. And with that, I'd like to thank a number of people. I'd like to thank Yeli, who's been an amazing student this year doing work with me on this topic and did a great job at this presentation. My mentors, John Mink, Erica Augustine, Heather Adams, for all their guidance along the way. We have a number of funders who have been really supportive through all of this work, our patients and subjects, and of course, the Tourette Association, who's given us this chance to talk to you all today. And with that, I don't think we have time for questions. Hopefully we were able to answer as many as possible.
All right. Well, thank you, Dr. Vermilion, and thank you, Yeli, for sharing this information with us today. There is a survey in the chat. I'm getting some messages that if you've already filled out a survey, it's not letting you complete it. So I have alerted our team about that. So if you wanted to send information, you can send it to support@tourette.org, and I'll make sure it gets included in the survey. You can visit our TIC-CON lounge for TA resources, as well as various information booths, and enjoy the rest of the conference. I think, I don't know if you have any questions left in the chat you want to address.
I think we probably don't have time to right now, but I apologize if we didn't get to your question. You should have access to our emails and feel free to reach out. We're happy to talk offline.
All right. Well, thank you very much. Have a great rest of the conference. Thanks for joining.
Thank you.
Okay. Bye-bye.
Bye.